Delhi Chapter of ACCLMP. I extend a very warm welcome to our esteemed speaker, Dr. Susruta Sen, and the panelists who have logged in and who are in the process of logging in. This is our first lecture of the first module of the ABLE course, a small attempt by us to make biochemistry more interesting, more intriguing to all of you budding biochemists. Before we start with the first lecture of the first module, let me introduce our speaker, Dr. Susruta Sen, to all of you. Dr. Sen is the Director, Department of Lab Medicine of CK Birla Hospitals, CMRI and BM Birla Heart Research Center, Kolkata. He did his MD Biochemistry from Bardhaman Medical College and completed his DNB in Biochemistry in 2005. Besides that, he has many more feathers on his cap. He has done PG Diploma in Diabetology, PG DHHM, and along with that, he is the President of the Association of Clinical Chemistry and Lab Medicine Practitioners. He is also the editor of Journal of Applied Biochemistry and Lab Medicine. He has been working as an NABL lead assessor and formerly was associated with CAP as international inspector. Sir has many research articles to his credit and has been actively participating as a guest speaker, speaking on the various aspects of clinical biochemistry in many national and international conferences. So over to you, Dr. Sen, for the first lecture. Thank you.
Thank you, everybody. And thanks, especially thanks a lot, Dr. Vinita, who actually have conceptualized the entire thing. Though I'm not a teacher, but here my lecture, if it serves good for any of you, I'll be feeling great. And this course is actually, we are trying to make it more interesting by not to go by a copybook like teaching, but rather teaching as a professional. So I hope the things will come out good and we'll have a new experience. Since it is a new experience for you as a learner, it's a new experience for me also as a speaker. So let's start the session with the first session is on error in clinical chemistry and how to identify the error and how to rectify them, what are the preventive actions and take around these corrective actions. And let's see how much interesting we can make the entire thing. So just let me share my screen of the presentation. So I would ask host to present the screen on my behalf. Thank you. So let's start with the first one. So it is identification of errors and troubleshooting in medical testing laboratory. So when we actually talk about the identification of errors and troubleshooting, so first we need to understand what is an error, what we call an error of a laboratory. So first, achieving a 99% level of quality, what does it mean? Is good, no? Is excellent. But achieving a 99% level of quality means you are accepting 1% of error. So it sounds very little, almost negligible, but 1% error, how much it can be? Just imagine the condition, 1% error in France, it means 14 minutes without water or electricity, 50,000 persons lost by postal services, 22 newborns falling from midwives' hands, 6 lakhs lunches contaminated by bacteria, and 3 bad landings in Orly airport. So sometimes 1% failure is very, very costly. We cannot even entertain a failure rate even 1%. So any error is a grave condition. Just look upon and find the facts, find the error of area of lacunae and take corrective action. But before that, we need to understand where the failure occurs, happen, so actions accordingly. So if I ask you, how often do you make mistakes? So we are very complacent. We never can do a self-criticism. Very few of us can do. If I ask a lab, so how often you do mistakes? So you may get answer, we never make mistakes. Last mistake what I made was in 1989. So somebody will brand me. We don't know. So there are so many things actually. Nobody can actually quantitate his or her own mistake unless and until there is a definite incident happens or a proper quality management system is taken place to actually take out the errors and correct it. So overall, the major reason is a poor quality management. So actually becomes accountable for a poor quality management as a whole. So first is inadequate attention to detail. So how many of you actually go through the standard operating procedure properly before going to testing or before going to implement the test actions? So these are the things, the first step for an error. Poor sample control. That is definitely later on we'll discuss it in detail. So I'm not getting in detail about that. Next, poor result verification. When you do the results, do you verify the results with your quality assurance system? Yeah, most of the times in most of the labs we don't. Then quality control and assessment. That's a priority thing nowadays. Previously in our college days, quality control was a concept which we were not actually very acquainted with. Even when I joined my career, when I joined my professional career, I had a very faint idea about proficiency testing or EQUAS. But when place, so this is what I think in our post graduations even not in detail been discussed. So then non-validated tests, that is very important. You have to use those tests which are validated. Without validation, the test usually doesn't give a right thing. Time pressure, this is a very important factor, particularly for a busy laboratory and heavy built laboratories. The major fact is the time pressure, where you need to poor workload management, that is a typical management call, and understaffed. Majority of the labs, this is a major problem, doesn't occur in government institutions or teaching institutions, but when you're talking about a private laboratory, understaff is one of the major problem we face nowadays. Now the proposed definition of laboratory error is a defect occurring at any part of the laboratory cycle from ordering test to reporting results and appropriately interpreting and reacting on this. So what do you mean by a proper test? A proper test is that which is ordered with a definite reason to either diagnose or rule out something. Number two, which has to be properly assessed, properly interpreted, and properly acted upon. So if any of this from the first to end, where actually some responsibility goes to the clinician as well, who is ordering the test and who is actually reacting on the test. So it includes everybody, not only laboratory personnel, but also the other persons who are actually reacting on the test. So that is why I say a proper result, an error-free result is which is a reactionable, on which you can react and you can treat your patient. Then we differentiate, as you majority of you know that very much, that we actually divide this into three categories. Okay, so first, insufficient pre-analytical errors, which accounts near about 65 to 68%. Then analytical errors, that means during the time of assay this error happens, which accounts for only 7 to 13%, and post-analytical error, which accounts near about 18 to 47%. So what kind of errors are those? Number one, pre-analytical errors mostly come from the sampling. What? First of all, incorrect sample. That means sample not taking a correct things, incorrect sample. Insufficient sample. That means sometimes the sample volume is insufficient to work on. Sample condition. Sometimes the sample condition is very bad. Sample condition is compromised during transport or something. Incorrect identification of patient, that also accounts to a majority part of error. And sample handling and transport. Suppose this sample is a very good sample to be worked on. A patient is given a sample for PRA, plasma renin activity. You don't do the test. You send the sample to Mumbai. So during the entire transport process, PRA has gone down to 0. So when you are analyzing it to be 0, it is not your analytic equipment failure. It is by the time it reaches, the sample is already almost gone. So there are the factors, which pre-analytical factors, which will come and elaborate later on, that pre-analytical factors are the major source of laboratory error. Then equipment malfunction can be a reason, or even sample mix-ups can be another reason. So these are all analytical. But post-analytical, what are? Reporting or analysis of sample error, improper data entry, very common, and turnaround time increase. And also, that is another condition which I am coming later on. They are all accountable for a post-analytical error. Now, if I elaborate it, so I have further differentiated that into pre-analytical, which is a pre-analytical error. So that can be improper test request, improper order entry, misidentification of patient or specimen. That means somebody else's vial has been taken in the name of somebody else. That happened with me several times. One time it happened, a patient with the same name, one of the patient of liver failure, one with kidney failure. Suddenly the next day, they found that the person who has a CKD suddenly developed a healthy kidney, but has a very bad hepatitis. And the opposite, the liver failure patient suddenly got cured from hepatitis, but having heavy CKD. So this can happen when you actually having sample swapping. These are very common in hospital atmosphere. Sample collected from infusion route, a very bad problem. When actually samples, when it is very much important that if you are taking samples from the same hand of the patient, then please, at least for a few minutes, close the IV infusion, because otherwise what happens, you are drawing blood which is mixed up with the infusion fluid. So these are a very common thing for a problem when you are actually having glucose or sodium chloride, you are running through infusion route in the same hand. Usually it should be taken from the other hand, but sometimes it may have happened that the other hand has been wrapped or bandaged. You have to take from the same hand. Please, for the God's sake, you stop the infusion first, wait for a few minutes, and then start taking. Otherwise, you may end up taking 50% blood and 50% infusion fluid mixed with a hair of result. So this is a very common mistake happens over there. And for procedure sample collection, erroneous sample collection, you may end up with hemolysis, clotting, insufficient volume, etc. So why I have termed the name clotting? Because sometimes we actually draw blood more than it is instructed to take. What happens? Then the entire vial that contains a good amount of EDTA, which is sufficient, supposed to anticoagulant for 3 ml blood. But if you have taken more than that, then that may not be able to actually keep the blood unclotted. So part of the blood may get clot. So CBC result and others will become heavy. Similarly, improper container. This can happen when you are drawing a serum sample. By mistake, you have drawn the serum sample in EDTA, or suppose you want to take a sugar sample, you have taken in EDTA. So these things can happen when you are taking in an inappropriate container, because each and every vial destined for the particular test, because it is done by this only. So if you mix up these containers, that can lead to a very bad condition. Then handling, storage and transportations are the issues where you may have a sample compromised during the process of analysis only. Now, pre-analytical processes are like sorting and pouring, aliquoting, pipetting, labeling, centrifugation. These can lead to some error. Analytical errors are actually less, like equipment malfunction, sample mix-up, interferences. Interference can be endogenous or exogenous. Endogenous means sometimes your own sample contains some interfering substance, which is very difficult to manage. Or exogenous means some other interferences coming as a from exogenous source. These are analytical errors, and obviously failure in quality control is one of the typical one. Post-analytical. This erroneous data entry, failing report or addressing the report, maybe excessive turnaround time and delay in reporting critical values. Now you may question me, how come it become a error? It becomes error. Unfortunately, a delay in reporting in critical values, in my opinion, is an error. Suppose you have got a potassium age of a patient and you are waiting and not saying it immediately, then when the report goes to the patient, this report is not of any help for this patient, because by this time the patient has got a cardiac arrest and died. So this condition during that period, your report may help the patient in autopsy, not for his treatment. And if the patient treatment is your report is unable to do a proper treatment guide for your patient, it is an erroneous report. Whatever, how perfect the report is, but report does not serve the interest from which it is being given. So it is an erroneous report to my point of view. Then post-analytical error, that mostly goes when you have a lack of communication between clinicians and you cannot interpret your reports properly to the clinicians. That is a long story that will come in the next classes, which are waiting for the next few weeks. So I'm not iterating over there. Now I'm coming to the next one. Laboratory test is influenced by how many things: lab environment, knowledgeable staff, competent staff, reagents and equipment has to be good, quality control has to be very stringent, communications has to be very good between clinicians and lab person and everybody. Process management has to be perfect and streamlined. Lean management, occurrence management has to be good. Moreover, most important, keeping of records are very important thing. A record keeping can help performance of a laboratory or increasing quality of the laboratory very fast, very good. Now, what I'm talking about first thing, complication of blood collection. So even from the area of blood collection, you can have so many errors happen. So failure to draw blood, patient may get fainted, may appear a hematoma, edema, and IV therapy. During IV infusion, you can take it. You can take at the time of hemoconcentration, patient in absolutely degraded condition, you have taken blood and all the reports are high because of the hemoconcentration. You may have a different veins. In old age, you can get this kind of veins, which you actually double puncture and do the hematoma. And lastly, if you take it in a hasty condition, and after taking, if you push the blood in a vacuum, that may lead to hemolysis, because if you allow the blood to run through the jet of a needle, it breaks down during the process and leads to hemolysis. So these are all these things can occur from the first step, that is blood collection. Now, hemolysis, which accounts for a majority of reactions. As you know, hemolysis in previous time used to have an interference with various number of parameters, like even creatinine, urea, bilirubin. But nowadays, with advent of the newer technologies, this interferences has actually gone down. But there are certain things which called endogenous interferences cannot be ruled out. RBC has got 200 times more potassium than serum. So whenever even a 4 or 5 RBCs is broken, that can significantly rise serum potassium level. So do the other intracellular enzymes like SGOT, LDH. In these conditions, you will find a hemolysis can raise these particular parameters very sky high, 3 or 4 or 5 times higher than normal, just because the RBC has broken down and the intracellular enzymes has come out in the serum, leading to a very high levels of those in serum. These can be avoided by using a proper blood collection process, training of the phlebotomist properly. Next, lipemic samples. The lipemic sample, as you know, if the sample has got lipemia, it interferes with the optical density and interferes with the immunoturbidimetry. So a lot of parameters are getting affected if the sample is lipemic. Lipemic means you will have a milky white serum. Serum will be appearing very thick because the chylomicrons are appearing in the serum, and that is the majority and most common problem with this is this electrolytemia, which is falsely diagnosed. So this case of this condition like lipemia, you may get a pseudo hyponatremia or pseudo hypokalemia because of that. And so that is why the lipemia is a big problem in majority of the tests. And the most important thing is that lipemia occurs mostly, number one, due to lipid profile abnormalities. Okay, that is unchangeable. You cannot do anything with that. But the most important problem which happens is not preparing the patient properly. So if the patient doesn't come with a proper fasting sample or proper fasting condition, this can happen that you may end up with a lipemic sample. So that is why proper patient preparation is a very, very important thing. And that is why giving proper information to the patient is our responsibility. Now we go in a nutshell with analytical errors. We term the analytical errors into two categories. One is random and one is systemic. So if you know what is random and one is systemic, you should be getting this analytical error idea about those. Random errors are those which occur all of a sudden and it is not present in the system. That means there is no guarantee that the same problem will recur once again and again after you run the samples again and again. So random means it happened all of a sudden. The reasons may come as a sudden occurrence, but since it is problem is not in the system, it may not be repeated. Like some sudden air bubble in sample, sudden voltage fluctuation just at the time of reading, this can be random error. But systemic error means the error which is present in the system, and unless and until you correct the system, the error will keep on repeating. So that is called a systemic error. So systemic error you may also call a bias, and that is the part of a QC rule. You know the LJ chart we prepare. You know the Westgard multi-QC rules. And these are the rules where you can find out the systemic errors or the bias. Just for a nutshell, I am giving you the quality control process so that you can understand the systemic error concept. Causes of random errors, first you have to understand. There is sudden degradation of reagent, control material degradation, operator error, follow macro reactions, could not follow manufacturer instruction. Outdated procedure manual has been taken. Preventive maintenance, water quality, these things all can happen in cases where I'm sorry, these are all systemic errors. These are not random errors. These can happen when you actually, this is keep on offering. The control material has got degraded. Until and unless you change the control material, the same will keep on happening. These all are actually systemic errors which can happen. If your sample is reconstituted, the same problem will remain. So this is called a systemic error, when some error which actually keep on happening and continues happening unless and until you change the system. Now these are the system waistguard rules that you know is how to identify and what to actually rule out systemic rules. So these are what 1-3A rule violation. This happens when the result is outside 3 standard deviation. What do? We reject the sample. We take the corrective action. We reject the run. Take the corrective action. And then only once it is corrected, we run the results. For 1-2A violation, this 1-2A violation, what we do? We only observe for the day 1, do not react and wait for the second. 2-2A violation means consecutively 2 days, the results are outside 2 standard deviation of the controls. On second day, we are taking a corrective action. And that is why it's called 2-2A violation. Similarly, if there is a beyond 1 standard deviation, after consecutive 4th day, we call it a 4-1S or 4-1S rule violation and take a corrective action against it. For 10 mean, that is in the one side of mean, all the 10 results are lying. We are allowing up to 10th day, and on 10th day we are saying it's a bias. So now you can tell me why there is so lack of patience in 1-3S, then patience increases. So that means the more the deviation, less is our patience. The 3S violation is so wide violation, so bad violation. I cannot wait for the second day. I have to take a corrective action. But when it comes to 2 standard deviation violation, I call it that the system is biased. System is actually shifted to one side. It's called biasness. So similarly for 4-1S, on 4th day, I'm calling the system to be biased because my deviation was not that high. It was only beyond 1S. So I am waiting up to 4th day to call it a bias. Similarly, in 10 mean rule deviation, I am waiting for 10th day to call it a bias. Another rule is that R4S, which is purely a random one, which signifies that the system is not biased, not tilted to one side. So now you can understand these are all analytical error identification and how you identify, yes, your system is having some systemic error or your system is having a random error. So these are the ways to find out errors in analytical process. Now if I go for post-analytical errors, long tact, transcription error, improper data entry, delay in critical alert reporting. I have already told in detail what is mean by delay in critical alert reporting. Wrong interpretation of results. That is another very important thing which most of the time. How do we achieve excellent performance in the laboratory? So there should be some corrective actions. We have dealt with errors, type of the errors. Now we understand how we achieve an excellent performance in the laboratory. So So first thing, proper sample collection. First, it's well-trained phlebotomist and nursing staffs guided by sample collection manual. So every lab should have a proper sample collection manual, which defines how the samples to be collected, what are the process, which are the containers you should use, what is the patient preparation you should take. These are everything is written in a sample collection manual, and ideally one phlebotomist should blindly follow the sample collection manual of the laboratory. And these are the things, if it is done properly, you can avoid muscle degradation, high calcium level due to tourniquet use, hemolysis, improper container, wrong timing of collection, sample contamination, and so many things. So even one sample collection manual properly done and properly training of your phlebotomist, you can rectify so many error areas. Now, solving out of control, you should check your IQC data and ECAS results very regularly. Not only checking does matter anything. Matters when you analyze the problem, identify the error, and establish a proper policy to identify and find out that. IQC data is for precision check. If you are finding your instrument or having not having a good precision, you should act on it. If you in ECAS gives you an idea, which is that your accuracy may be questionable, how to identify the lack of accuracy, that you have to establish and take a remedial actions accordingly. Now, for equipment, proper acquisition, installation, validation, proper maintenance of equipment, proper calibration, troubleshooting, timely service and repair, and most of the important thing, keeping records of each and every breakdown instrument and control and calibration. That helps to achieve a proper quality analysis. Moreover, you need to have a process control. That is, the first of process control comes is quality control. Instituting good quality control in your laboratory is the first and foremost thing. Then proper sample management. As I told you, this training of not only phlebotomists, but training of all the technicians, how to manage samples properly. Then validation of method. How to validate the method what you are using. You cannot use any kind of method, whatever is available. It is not a experimental mode. It's a mode when you are analyzing the results will be worked on. Do assumptions validation is the most important thing. Method verification. There are validated method may come to your account, but you have to verify whether it holds true for the patient which you are serving. So method verification is also a very important thing in this case. Moreover, how to minimize transcriptional error and improve TAT. LIS system is very important nowadays. Don't go for a manual typing and manual data entry. There is chance of error. We have instrumentation LIS system where the results are directly thrown to the lab information system by interfacing of the system and LIS, so that this transcriptional error and TAT can be grossly improved. Now, moreover the things, records and documents has to be collected, reviewed, storage and retained properly. And revision of documents and control and distribution is very important. You have made all the good things, standard operating procedure, sample handling manual, and kept in the control of lab director. What does it serve? Nothing. So it should be distributed to the area which has to be there. Means a sample handling manual is not to be placed on a director's chair, director's table. Rather, it should be on a phlebotomist table, and it should be read by the phlebotomist, understood by the phlebotomist, and followed by the phlebotomist. Similarly, a standard operating procedure of a test should be read and understood by the technicians more than the lab director. Now, the laboratory assessment can be of two categories. One is internal assessment, when you are your own examiner. So you can use quality indicators for a detailed throughout the year process. You can institute some internal audit programs, or you can have some audit reviews. Now, when your external person is judging you, the areas of proficiency testing or ECAS, where you against comparing against with others can give you a right idea where exactly you stand. You may ask for inspections, and moreover, your laboratory, you can go for accreditation. When you go for accreditation, automatically you have to improve your quality of your laboratory. How to improve the process? So you have to find the opportunities of improvement. Stakeholder feedback is very important. Resolution of problem is one of the key to improve your quality. Unless and until you are looking forward to the problem, or I should say looking forward to the complaints and resolve them, you cannot improve. Then risk assessment, where you can assess where the maximum risk of error can happen. Then according to risk assessment, you can take preventive actions for those which have not happened, but there is chance to happen, and corrective actions where some error has happened and you need to correct it. So these are all as a whole improves the process and minimizes the error. All of now it is a boring sessions are going on, where I'm giving all kind of theories, so you might get bored of. Now it's time to actually find out what exactly happens in our and how you can find out errors. It would have been fantastic if there is a bi-directional flow so that I can get some answers, but unfortunately it is not. Kindly follow the cases. Now, first case, a patient of known diabetic admitted with history of loss of consciousness, query hypoglycemia. Patient was initially treated and blood sent for investigation. And when we got investigation results, we are really stunned. Urea is 5.4, creatinine 0.31, sodium 78 only. This sodium patient usually doesn't survive. Potassium 2, and random blood sugar is 675. So the most problem is that patient known diabetic. Yes. So we have given good amount of 5% dextrose. The question is, are you going to believe that? If not, what is the thing you are suspecting over there? This is nothing but I told you as a very common mistake that happens in the wards when sisters and even doctors do take blood. They don't take the pain of pricking the patient again. What they do, they pick up the line from where infusion is running and draw blood from there. So this is what happened exactly in this condition. The blood was drawn, was totally mixed with 5% dextrose, and that is why for that reason RBS is so high. But because of the half dilution with dextrose, you may get all the results are extraordinarily diluted. Maybe sodium would stand 140, potassium 4, creatinine 0.6, urea would have been 11 or 12. So this ended up with diluting all other parameters and excessively showing random blood sugar. So this happens when you are using IV infusion or you are taking blood from IV infusion. This is a purely contamination by dextrose. Now, there is, first was, what kind of error was that? Obviously, absolutely pre-analytical error. Now we come to the second one. Diabetologist visited a lab with a complaint that all of his patients are getting diagnosed as uncontrolled diabetes because constantly we are giving high HbA1cs, but which is not matching with the sugar status. Now, when I just, after this complaint, I looked after my records, I'm finding that my last month PT was outlier with a upper side bias of of plus 3.54 SDI score. That means I'm quite biased on upper side. So far my PT result is showing. Now I look down the LJ showing that throughout the month I'm having more than one standard deviation of IQC result during that period. So that is totally been ignored. And there was a strong positive bias of the analytical instrument going on, and I was releasing the report, bias reports with +2 or +3 A1C of a normal constantly. So this is a typical error, or you can call it an analytical error, when there is a problem with some calibration of the instrument and there was an outlier in accuracy, outlier in precision, the showing constantly there is a systemic error which has been ignored until unless I got the complaint. Next, case 3. This is a peculiar case. A patient suffering from multiple myeloma. Test carried out during treatment shows calcium 9.4, phosphorus 32 mg per dl. Impossible for anybody to live with this condition. Urea, creatinine are more or less okay. But I know in myeloma cases, I'm referring it to a dry chemistry system. The entire result has been different. Calcium 9.6 more or less similar, but phosphorus came as 5.5. This is a typical process when a myeloma, high protein in the blood, myeloma cases where interference happens in a liquid chemistry system where actually phosphorus is been interfered in its phosphomolybdate assay. But in dry chemistry, when the blood is percolated from the layer, it is this interfering part is taken off. So here you get the exactly right phosphorus result of 5.5. This is a typical of an indigenous interference. This is also an analytical error, but I should not call it an error. This is an example of an indigenous interference where your blood material has got interfering substances which cannot be dealt with some system, but can be dealt with even more advanced system. Now case 4. Look at this. How many mistakes you can find? It should have been an interactive session, but still I'm giving you some time. With your own mind, you find out some of the problems and let me know what you have found. I cannot know what you have found, but you shall judge yourself. I can at least identify several problems. Number 1, the needle angulation is improper. Number 2, this person, despite of decontamination of the area, is putting his hand on the area of particularly when the blood is drawn. So he is contaminating the area and therefore it is an error. Number 3, not wearing gloves. So there is a chance of contamination even further increased. Last and not the least, very tightly bound tourniquet. We don't use tourniquet like this. He is not even using tourniquet. He is using the gloves as a tourniquet. So it may lead to a strongly muscle degradation, lead to high CPK and also high calcium values in blood. So there are at least 5 mistakes I have found. Number 1, contamination, no gloves wearing, wrong angulation, too much tightening of this tourniquet, and not using tourniquet, a very common thing, using urinary catheter or gloves as a tourniquet is a very common mistake they do in wards. Please don't do it. It actually affects the results very badly. Now, this is a very fantastic example. This is one of the loving example. I love to give this example. Is that patient admitted in ICU. This happened when I was just about 2 years of my professional career. The morning blood sent at 8 a.m. blood for electrolyte and lipid profile. But the lipid profile is coming like this. Cholesterol 298, TG 3590, sodium 112, potassium 2.4. Now consultant confused and called me up saying that last night electrolyte reports were absolutely normal. How can this happen? Then the morning results are so weird. There is about a drop about 10 or 15. Last day it was 137. Now I just worked it out. I got the information that patient is on TPN. So it raised my confusion that TPN, what do you mean by, you mean what, know what is TPN? This is Vitrinix. It is given for 12 hours in to a patient. Throughout, the patient is unable to take anything over through mouth. So they give it via an IV infusion. It's a thick hyperlipid containing solution, is given only at night when patient is sedated. Most of the time in CCU, that is the protocol. So for this kind of patient, when you are taking morning 8 AM blood, it is full of chylomicrons. Why we take a morning sample of overnight fasting of 12 hours? Because we allow all chylomicrons to be cleared from sample, from the blood, and only we get the triglycerides, not chylomicrons. But here, the ideal sample should be 8 p.m. for lipid profile, not 8 a.m. because just after stopping the TPN, the blood was drawn and taken. And what happens? As you know, severe lipemia leads to pseudo-hyponatremia and pseudo-hypokalemia. So because of this high TG or high lipemic sample, the sodium potassium came very low. So if you have started, if you have trained your nurses properly, the lipid profile sample should have come at 8 p.m., not at 8 a.m. Now this case 6, how you can understand. The pre-dialysis patient was urea 188.4, creatinine 9.78, potassium 7. Now after dialysis, the result came urea 44.2, creatinine 4.02, potassium 42. So easy enough, easy to get the diagnosis. It is clearly a transcriptional error. So it should have been type 4.2. Just the point moved one side to the right and made the entire thing heaven. So this is also an error, but it is a post-analytical error. This is a error in typing. Case 7, a very, very, very interesting case of mine. I love this case. So it was, I found myself as a Sherlock Holmes when I actually cracked it down. The patient sample was drawn from OPD. Patient has given blood for regular health checkup. Results was impossible to interpret because a hale and hearty person having sodium 170, potassium 4.5, urea 2.2, creatinine 0.89, and glucose 96. So first I looked up the sample. I found the RBCs were not properly clotted in clot vial, partly non-clotted RBCs are there. Despite of that, that 4 hours have been gone by this. Urea, the entire concentration gone to urea. Why it is 2.2? How many of patients you have got about urea 2.2? I called the phlebotomist and interrogated him very badly. What did I find? By mistake, the phlebotomist has drawn only sodium fluoride sample in sodium fluoride vial, and later on he came to know or understand that the serum is also required because the patient is given blood for sodium, potassium, urea, creatinine also. So he just transferred some of the sodium fluoride contaminated sample to serum vial and took to us. What happens because of presence of sodium fluoride, sodium was very high And since fluoride is an inhibitor of urease enzyme, urease could not react, leading to a very low urea. So my total area of suspicion went to urea, and through that I cracked down this thing and got the right diagnosis that it was a pre-analytical error. Sample was taken in sodium fluoride and then transferred to serum. This can happen very frequent times, and if you don't treat or don't train your phlebotomist, they do this kind of mistakes very regularly. Now, on medical checkup, results of a superintendent of police is a very funny thing actually. So the superintendent of police have got all reports normal, heavy build, fantastic build person, but always coming high CPK. He has done echo, ECG, everything, but every time he got stuck with this. He came to me and he was very annoyed. Superintendent of police, I had to give him more patient hearing. So he said that I'm so hell and hearty person. How can I get a heart attack? I am not getting fit because of it. I took a total interview. What is his routine, you know? He wake up in the morning, go for a walk, then he come back, do heavy gymming because he is a bodybuilder, he likes heavy gym. And after that have some water and something, straight comes to our hospital for a health checkup. All the 3 times he has done that. Then I said that yes, if you have done a heavy gym, that leads to some of the muscle fibers to be broken immediately, and immediately there will be a surge of CPK for a few hours. If you are coming immediately after gym, you are going to have this CPK. Then I asked him to take a proper rest and come in a fasting state and do his CPK. So these are the small factors, but very inevitable factors that do happen when we face such situations. So this is also a pre-analytical error where a patient preparation matters. Case 9. Again, I am saying another one. A patient long-standing diabetic but well controlled. Now he has come with this. Fasting 102, PP 298, A1C 6.1%. Does it match? No. The PPBS does not match. And who is accountable? The lab person. But who should be accountable? The clinician. Because this person has not come to diagnose diabetes. This person has come to follow up whether he is in control after taking medication. So the PP should be taking just following every day's proper routine. That patient has to be taken medicines in the morning, do a normal breakfast, take all the medications, take lunch at particular time, 1 p.m. or 2 p.m. on what time you are actually taking lunch every day. If there is any medicine in before and after lunch, you have to take that. You exactly should take PP 2 hours after lunch. What happened here? The patient did not take the medicine on the day of testing. So fasting came okay because last night medicine was taken. Patient did not take medicine on the day of testing and done PP at 11 o'clock, taken food at 9 o'clock with fullest possible in the lunch manner. What happens? Suppose the patient is given glimepiride. The glimepiride will be absorbed in blood about 1 hour. Why we give it before breakfast? Because we entertain this glimepiride to be in action so that in the next time when the glucose surge occurs during a glucose load of lunch, glimepiride pulls it down and goes to a normal range. So if you are really in a follow-up mode, then you should instruct your patient to give what time PP and when to give a PP sugar. Because at the end of the day, if you chase 298 and give a higher medication, patient is going to have hypoglycemia. So the responsibility lies on the shoulder of the clinicians as well. And if clinician doesn't do his part, to save our own, we have to educate the patient about it. That how to take PPBS and why you should take medicines and follow all normal routines like other 29 days, because if you don't be in a routine of other 29 days, your 30th day will not be the representative of previous 29 days, and you are going to be treated on your 30th day report. So that is one of the typical example of a pre-analytical error when patient education and patient preparation is very much required. Then is case 10. This is another typical error. This made me confuse a 4.6 fast HbF of a hemoglobinopathy of an 11 years old male person. So this high A1C is not at all acceptable for me. So I'm totally confused what to report. Neither fits in with any of them. So I inquired, and after detailed inquiry, I found that patient name was entered wrong. It was 11 months, not 11 years. So when the age converted to 11 months, it becomes so easy. Less than 1 year, there is possibility of a remaining of fetal hemoglobin. So you should ask the baby, ask the test to be repeated after 1 year of age. But just because it is not written as 11 months, it is written as 11 years, the entire thing jeopardized. My entire diagnosis was in confusion. This what happens with a very small entry error leads the entire thing to evac. Last one. A patient admitted in a nursing home with history of high-grade fever, neck rigidity, and very drowsy. Total count is high, CSF protein very high, glucose low, parcels plenty. But when the culture report sent to a highly reputed lab, culture report shows no growth. How is it possible? There should have been some growth. It's a bacterial meningitis for sure. This is the answer is again improper knowledge or improper training. The CSF was kept in refrigerator. As the culture growth was of Haemophilus influenzae, it is a thermosensitive, the bacteria died. So very next day, when the CSF stored in a refrigerator was sent to next day lab, the lab found nothing in a culture. So this is also a very typical example. You should know how to preserve your samples also. So classification and prevention and correction of laboratory errors. These are the things where you should recognize, make something responsible, find the preventability of it, and also the most important thing, you have to understand the impact on patient care, how much it is impacting on your patient care. If it is high, your priority of correction is faster. If you are not that high, you can take a corrective action in a stepwise manner. Implementing quality management does not guarantee an error-free laboratory, but it detects error and that may occur. And if you detect the error, you have a chance to rectify, correct, and take preventive action so that it should not recur. That is why the importance of quality management system is so high. Conclusion. A practice of keeping a record of the errors at all stages of analysis and then devising corrective strategies for their prevention can gradually free a laboratory from such errors. So, to conclude, we would like to state that we as lab practitioners need to adopt a holistic approach towards laboratory diagnosis and function in concert with the clinicians to provide effective services to the patients. Adoption of quality control in all the phases, and not only the analytical phase, but with pre and post analytical phase interpretations and talking to clinicians as well. So now I invite questions. So this is what. Thank you. I'd like for a question answer session now.
It was a great question answer panel. Because the participants cannot ask, so I'll request you to please answer them by typing on the results.
They can type the questions. I can gradually one by one answer them.
I think one you have already answered.
I can't get the questions actually.
Should I read now? Read them out?
Sure. Okay. No, I think let me find it out. Yeah, there are 6 questions, I suppose. Yeah. There is only one question I am finding. If fluoride inhibits urease, how the urea decrease? Just a minute. So there are fluoride. Actually, the question. Yeah, some of them is saying if fluoride inhibits urease, how do urea decrease? So the urease reacts on urea. Okay. So and the change is detected. So if urease reaction is inhibited, there is no change in optical density. So urea is detected in 2 ways. So the change in optical density, delta A, is detected, and we actually analyze the urea accordingly.
यही तो चीजें इम्पोर्टेंट होती हैं, कुछ क्वेश्चंस आ रहे हैं.
So there are so many, I just can't get it actually. Consistently low sodium in our lab around 130, but QCs are passing daily. Passing daily, sir. What could be the pre-analytical reason? There is no pre-analytical reason, I suppose. What you need to do, you have to come out of your lab mean. It's a question of safe. Question from Saif. So he is saying the constantly low sodium in our lab around 130, but QC passing daily. So are you evaluating whether your QC passing daily against the pack insert mean or a lab mean? Sometimes it might so happen that with the time, the lab mean decreases gradually, unknowingly, and comes to a range where you are getting a low results, but lab mean is still showing that your precision is okay. It is good, precise, as it is coming around 130. But what you need to do, you need to have a fresh calibration, or you need to ask your, if it is direct ISC, you need to ask your manufacturer to come and calibrate the instrument once more. And now you check it with the pack insert mean, you may get a change. Last case we missed out the error, there was some network issue, okay? So the error, last one is yeah, that is the storage. I told you, no? The Haemophilus influenzae is thermosensitive one. So the person has stored in a refrigerator. That led to the death of all Haemophilus influenzae. So the next time, the culture shows no growth. Any quantitative relationship between, yes, that you need to understand that when you are talking about direct or indirect ISC, I have a paper on that, you can go through on that. So that what happens, we actually run the serum through the electrodes and they pick up the voltage potential. Now what happens in case of lipemia, as sodium potassium is not soluble in lipemic sample. So suppose 30% is lipemia in the sample. So only 70% is the liquid portion in the serum. So when it is sensing the in the electrode is taking this value against, suppose 1 ml of the sample passing through, but actually in the sample 30% was lipid where no sodium potassium was diluted. So taking 70% value and interpreting it as 100%, and that is why in both ISC and in indirect ISC, sodium potassium is wrongly under-calculated when there is lipemia. So you are saying your ECAS is showing proper values, then why are you getting worried? Take 130 as the right one. It might so happen that most of the cases where you are going through, results are around 130 in genuine. I have a paper on that, spurious hyperphosphatemia in case of multiple myeloma. You please go through that, you will get the answer. Any other questions?
Sir, I think some of these questions can be covered when we talk about the interpretation of clinical chemistry reports,
Yeah,
which is there in the next session, that is on Wednesday next week.
most of them.
So some of the questions we can take there at that time also, because that will also be a case-based analysis of reports, because now questions are continuously pouring in.
Yeah, it's
And
it's impossible to answer all of them.
Exactly. So we can just take a note of these questions, and in the next session, we may try to cover these points.
We'll look out, we'll screen out the pertinent questions, and after that, we'll try to answer them.
Okay. So I'll extend a very warm thanks to Dr. Sen for such a nice talk. It was really very interesting. Especially the case studies were really great for understanding the nuances. And a big thank you to all the participants, because this is something which has been planned for all of you. And I could see the maximum number of participants at one point was 130. So that I'll consider to be a very big achievement for us. It's our maiden venture and our maiden lecture. So thank you all, and hope to see you next week.
Thank you.
Thank you. Thank you, sir.
Thanks a lot.
Thank you. The people may now leave the meeting. The class is over.